Isokinetic Workshop Level 1. Theory of Operation. Objective. Understand isokinetic principles. Apply these principles when selecting a protocol. Be able to interpret and analyze the data for comment and recommendation. Manual muscle testing by Kennel and Kennel, revered as a gold standard by clinicians with the testing and measuring of muscle strength. MNT has its limitations. The studies have raised questionable inter-rater reliability. The repeated training of testers are required. Limitations to detect discrete differences in strength. Difficulty in stabilizing patients. Bohannon and Norrow are of the opinion that diagnostic accuracy was never greater than 78%, casting doubt on manual muscle testing as a screening test for strength impairments, and that is not sensitive enough to detect small to moderate increases of strength for rehabilitation. Therefore, objective measures should be used in clinical settings. The principle behind isokinetic exercise and testing is that the lever arm moves at a preset fixed speed, allowing for accommodating resistance to the effort the subject applies. This means that the resistance encountered by the subject is equal to their effort. The set lever arm speed allows the dynamometer to measure the torque output by the patient throughout the range of motion. This is unlike manual muscle testing, which is a static test, and isotonic testing, which measures strength at the strongest portion of the range of motion and is also affected by speed of movement. Isokinetic resistance will accommodate to pain, fatigue, changes in length tension curve, and biomechanical leverage of the muscle, allowing for a safe, efficient exercise and testing. Because of the accommodating resistance, the muscle is loaded throughout the range of motion. The patient's resistance is then equal to the effort they apply, regardless of the length tension curve, which varies with isotonic loading or pain, therefore making it a safer and more efficient form of exercise than isotonics, which maximally loads the muscle at its weakest points. Also, when the patient begins to fatigue and they are unable to continue with the exercise, they are still loaded maximally with the isotonic resistance, unlike isokinetic resistance, which will accommodate to this variable. Much like the range of motion carryover effect seen with isometric exercise, there is a 30-degree range of motion carryover with isokinetic exercise. The carryover is 15 degrees on each side of the end of range of motion exercised. This will allow for strengthening of the muscle within the exercise range of motion. There is also a 30 degree per second physiological overflow between the speeds. This is important with exercise training, as each speed does not have to be exercised. For example, if you start an exercise at 60 degrees per second, you do not have to exercise at 90 degrees per second, as the overflow will compensate for this. The variety of speeds and physiologic overflow has a distinct advantage over isotonics, which are usually performed at 60 degrees per second. Isokinetics is used to identify, treat, and document physical impairments that cause functional limitations typical of activities of daily living, sports injuries, and orthopedics. Principles of speed. Velocity spectrum in degrees per second. Slow, 2 to 180 degrees. Medium, 180 to 240 degrees. And fast, 300 to 500 degrees per second. The one principle of isokinetics which is important to remember for clinical applications and testing is that torque production varies with speed. The lower the preset speed, the more torque can be produced concentrically. Increasing the preset speed, concentric torque production will decrease. More motor units can be recruited at lower speeds than at higher speeds, allowing more torque production. The converse is true eccentrically. The higher the preset speed, the more torque will be produced. This is due to the nature of eccentric muscle physiology. Compressive and translational forces across a joint will vary with speed. Faster speeds have less compressive forces than slower speeds. This is important to remember clinically, as it will apply to treating specific pathologies. For example, Patellofemoral pathologies should be started out at higher speeds to reduce the compressive forces across the joint, which in turn will protect the joint surface and will be more comfortable to the patient. On the other hand, a shoulder with multidirectional instability should be started out with lower speeds to use the compressive forces to stabilize the shoulder in the glenoid fossa. Translational forces across the joint also vary with speed. The knee joint experiences anterior translation of the tibia with slower speeds. This is due to the force vectors created by the quadriceps and the biomechanics of the knee. Slower speeds should be avoided or used with care when rehabilitating the ACL deficient or post-surgical patient. The opposite is true with the shoulder. The faster the speeds, the more translational movements. This is also due to the biomechanics of the joint and the force vectors created by the musculature. The use of speeds are also important with curve analysis, as deficits will be more pronounced at the slower speeds. This is due to the fact that the muscle has enough time to recruit motor units and generate torque, allowing compressive and translational forces which may elicit pain. In the case of an ACL deficient patient, translation of the tibia, which will alter the biomechanics of the joint, and this is apparent as a dip in the torque curve. At higher speeds there will be more artifact spiking. This is due to the lever arm decelerating into the end stop, causing a spike in the torque curve at the end range of motion. This may appear as a peak torque value and can be eliminated. Beneficial training effects of isokinetic exercise. Since the subject essentially needs to catch the machine to develop resistance, isokinetic exercise helps to develop some of the following. Time rate of tension development. Upslope of a curve indicates how quickly torque can be developed during a muscular contraction. An example of this would be torque at 0.20 seconds. Decreased reciprocal innervation time. Time interval between the end of the agonist contraction and the beginning of the antagonist contraction. For example, the time between the ends of the quadriceps contraction to the start of the hamstring contraction. Strengthens muscular tendinous junctions. This occurs with any resistance exercise as the body adapts to the demands imposed on it, the set principle. Isokinetic testing. To determine the best type of test for a situation, avoid thinking of tests as a means of measuring strength. Instead, consider the type of test that will help identify problems of overall muscle performance during functional activities. Therefore, isokinetic testing offers significant clinical controls, such as isolate particular muscle groups, determine contraction types and range of motion, and accommodated resistance. As mentioned before, the bottom line is a set lever arm speed measuring muscular output by the patient, making it an efficient method for the assessment of muscle performance. Isolation of a single muscle group for assessment is possible. This is easily done by choosing specific contraction types, which allows for assessment of the concentric or eccentric component of the muscle. Range of motion is another controlled aspect of testing or exercising. By controlling the range of motion, tests and exercises can be performed in an area of pain-free range of motion. The accommodating resistance offered by isokinetics will address pain issues and variations in the length tension curve. This can be seen in the peaks and valleys of the strength curve. When a patient experiences pain or a weak point in the range of motion, it will be represented as a dip in the torque curve. Perhaps the most important reason for isokinetic testing is that it provides an effective way to obtain objective measures. These objective measures are valid, reliable, and reproducible. Many studies have been performed to document this validity and reliability. Isokinetics assess the muscle performance values. A specific muscle group can be assessed for the following values, to name a few. Peak torque, highest muscular force output similar to a 1 repetition maximum effort in isotonics. Work, a more functional value of muscle performance, as work is torque sustained over a distance in an active case and torque sustained over time in an isometric case. Power, this is how effectively the muscle can perform work over time. These values and others will be explained in greater detail later. Isokinetic testing can be used to provide valid, reliable, objective measure of a muscle's performance time after time. Following the guidelines established by Kevin Wilk can further assist these measures. The goal of these parameters is to prove reproducibility of the test results, and the parameters are as follows. Patient education. As with other modalities in the clinic, a patient will be less apprehensive and respond more favorably to treatment if they understand the procedure. Educate your patient verbally about isokinetics and allow them to have a few practice sessions if possible. This will make them more comfortable and will produce better results as there is a learning curve associated with new movements. Wilk has shown that a patient educated through practice sessions is 80% more likely to give maximal effort of a test, while a patient who is not comfortable with the activity will only give 60% effort. Test order. It is important to remember that a patient likes consistency. To make your results more reproducible between test sessions and patients, intra-test, your patient should perform the test in the same order every time. The key to a good test session is consistency. By keeping the same order every time, it will reduce the clinician's time in administering the test. This will also make your patient more comfortable with your skills as a tester. Axis of rotation. This is important to allow for safe movement of the joint and allows for isolation of muscle groups. Should there be any unnatural movement of the joint, it will cause poor biomechanics and in turn can cause joint surface irritation and substitution of the muscles being tested. Warm-ups. Warm-ups are broken down into two types, general warm-up and a pre-speed warm-up. A muscle which is properly warmed up will function more safely and efficiently than a muscle that is not. It is recommended that the patient perform a general cardiovascular warm-up of at least 10 minutes, and this should be done by concentrating on the body part being tested. For example, if the shoulders are going to be tested, warm-up should be performed on an upper body cycle. Pre-speed warm-ups should consist of 3 submaximal efforts and 1 maximal effort. This will allow the patient to get a feel for the speed of the lever arm and what it will feel like to apply submaximal and maximal effort at the various speeds. Stabilization. Stabilization is important to prevent accessory movements of the segments. Accessory or compensatory movements may allow the patient to obtain high torque values. It is recommended to use the straps provided on the chair to help stabilize the patient. Make sure that they are snug but not too tight, as this may cause ischemia or change the length-tension relationships of the muscles being tested and ultimately affect the test results. Position. George Davies recommends testing in non-biased positions so the muscle is then unaffected by active or passive insufficiency. It may be necessary to recline the seat to reduce the pre-stretch effect of tight hamstrings. Positioning will vary with each body part tested. Remember to be consistent when administering multiple tests to the same patients. Verbal coaching. Research has been done in terms of how a patient is affected by verbal coaching. A patient will respond to any verbal encouragement that is given. If the clinician is not consistent or another clinician administers a test without verbal coaching, this may affect the test results. Visual feedback. As with verbal encouragement, visual feedback is another variable that could affect the outcome of the test result. Research has also been performed regarding these effects and has been determined that there are benefits to both. During a training session, it is helpful to have the biofeedback that may provide motivation for the patient. However, during a test, the patient may fatigue sooner if they are using visual feedback, as they may try to improve torque output from the previous repetitions. Patients may also use the visual feedback to try and match the previous repetitions, giving possibly submaximal efforts and therefore alter the results. Angular velocities. Choosing angular velocities is important. Traditionally, slow speeds have been considered strength speeds, 60 degrees per second to 120 degrees per second, and fast speeds 180 degrees per second to 300 degrees per second have been considered endurance speeds. This is a fairly true assumption. However, ADLs are comprised of variable speeds and muscle strength needs to be assessed as such. Peak torque, work and power can be assessed at any speed chosen. It is important to remember to be consistent between tests, as this allows for comparison of like values. Normative values have been established for specific speeds. Calibration. Calibration of the system is necessary to ensure the validity of the test. The Birex dynamometer does not necessarily need to be calibrated, rather calibration verification is performed. Calibration verification should be done at least once a month. If the Birex is being used for research purposes, calibration verification may be performed more frequently. In such cases, it should be performed after a predetermined number of patients. This will add credibility and reliability to the research. Planes of motion tested. When isolating a particular joint, it is important to remember the biomechanic patterns and movement specific to that joint. For example, to isolate the quadriceps and hamstrings, flexion and extension occur in a sagittal plane. This ensures a safe movement pattern and isolation of these muscles. Gravity effect of torque, or GET. This is essentially the torque produced by the limb and the attachment. For patterns affected by gravity, it is necessary to measure GET. This is done by the dynamometer, recorded by the software, and added to movement patterns against gravity, and subtracted to movement patterns assisted by gravity. For example, if in the knee the quadriceps work against gravity and hamstring are assisted by gravity. Therefore, GET is added to extension and subtracted from flexion to compensate for the effect of gravity. In doing such, an unbiased torque value is given. There may be a difference between uninvolved and involved. This difference may be due to edema or muscular atrophy. GET should be measured at the same point in the range of motion each time, particularly in a position which is unaffected by any possible muscular tightness. The optimal angle for knee testing is 30 degrees. This again allows for standardization between tests and subjects. Test repetitions. Repetitions should be kept consistent between test sessions. By increasing the number of repetitions, the patient may experience fatigue or discomfort during the test. At least 3 repetitions are needed for the software to calculate the test data, provided the patient meets isokinetic speed. Slow speeds are generally conducted at 5 repetitions, faster speeds usually performed at 10 to 15 repetitions. A standard isokinetic knee testing protocol is as follows: 60 degrees per second, 5 reps, 180 degrees per second, 10 reps, and 300 degrees per second, 15 reps. Isokinetic system level. This last parameter is just as important as the first. If there is excessive movement of the dynamometer, it might be displayed in the test results. This is a variable which can be controlled. The machine should be placed in a stable area away from excessive clinical traffic, as the dynamometer is very sensitive. If the machine needs to be moved, it becomes unstable. Make sure to find a stable space within the facility. Data analysis. Numerical analysis. The Birex software collects and stores real-time data. Every time test data is recalled, regardless of the actual test date, it will be exactly as it was collected during the original test. This is beneficial when comparing data points between tests. The question you should ask yourself with data interpretation is, what do I want to do with this data? And what am I trying to determine from testing? Do you want to use the data for patient advancement, patient discharge, baseline information, before rehabilitation or training program, etc.? The following section will define the test data and describe what may affect each variable. The basic knowledge should be helpful to interpreting data. As mentioned before, you should determine what you are trying to gain from testing. Use specific criteria for interpretation and consider the following. What do you want to do with the data? Research, patient advancement. What are you looking for from the data? Percentage deficit, acceleration, deceleration time, etc. Population criteria. Age, sport, position, activity specifics, pathology, curve analysis. Use other clinical tests and correlate these findings to your isokinetic test result. This is analogous to a physician using X-rays and MRIs to confirm suspicions of a fracture or a torn ligament. You need to be a detective, and the test results are clues to help you solve the clinical mysteries for a successful rehabilitation. It also facilitates the building of a body of evidence for medical legal reporting and supportive data. Reading test results. The first concern of data interpretation is to determine if the test is reliable and valid. This can be done in two ways. Coefficient of variance. This determines the reproducibility of the test based on the amount of variation between repetitions. Large muscle groups less than 15%, small muscle groups less than 20%. Work in your first one-third and work in the last one-third. This will determine when the most effort was produced and the amount of effort given during the test. More work should be produced in the first one-third of the repetitions if the patient is working at maximal effort and less work during the last one-third. This is graphically represented as a down slope from left to right. Acceptable coefficient of variances are as follows. Like we said, large muscle groups less than 15%. Large muscle groups are primarily movements that cover a larger range of motion and include knee, shoulder, back, elbow. It is easier for a patient to produce torque for these joints due to increased time for major recruitment. Smaller muscle groups, less than 20%. Small muscle groups are joints which cover a smaller range of motion and primarily include ankle and wrist patterns. After determining the acceptance of the test as valid or invalid, analysis of the data is the next step. Data analysis can be made either as bilateral comparisons, in which case percent deficit is looked at, or unilateral comparisons, in which use of normative goals are used. Unilateral muscle ratios are also important to look at and will also be mentioned. Percent deficit. Bilateral deficits are gained by comparing the uninvolved to the involved. The software calculates the percent difference, and percent differences between 1 to 10% are considered acceptable. A negative value implies the involved side is stronger than the uninvolved, provided the uninvolved was tested first. There are limitations to this range. For example, if you are treating a right-handed sports person, such as a tennis player, you will need to rehabilitate the involved right extremity to a percent difference to be greater than 10%. This is due to the fact the uninvolved side is not as dominant in activity and therefore should not necessarily be used as a baseline measure. The acceptable range is negative 10% to positive 10%, except in special cases where side dominance is important. Note, there are limitations to bilateral comparisons. Should the uninvolved limb be deconditioned, secondary to lack of activity, insufficient rehabilitation, or bilateral injuries, then percent deficits are not helpful in this case. This is where it is helpful to look at other measures, peak torque to body weight, for example. Peak torque. This is the highest muscular force output at any moment during a repetition. This can be determined within each rep for the entire set. Peak torque can also be evaluated specific to time, for example torque at 0.2 seconds, or to range of motion, for example torque at 30 degrees. Peak torque indicates the muscle's maximum strength capability. This is also the equivalent to a 1 repetition maximum 1 RM isotonic strength test. Peak torque is an absolute value. Used alone, peak torque is difficult to assess the strength specific to a person. For example, two subjects can produce a peak torque of 100 Newton meters. It would appear they are equally strong. However, if patient 1 weighed 100 kilograms and patient 2 weighed 200 kilograms, it is then more apparent which patient is stronger. Peak torque to body weight. Peak torque is represented as a percentage normalized to body weight and compared to an estimated goal. This value is more relative and pertinent to functional activity. By looking at the previous example, patient 1 is stronger than patient 2, as they both produce the same peak torque. In looking at body weight, patient 1 is 100 kilograms lighter than patient 2. This value can be taken to the normative goal chart. Joint movement position, speed, male and female ranges are also represented. The test value should fit into this range. Patients that demand high performance should be at the high end of the range or beyond. This is perhaps one of the better indicators of successful rehab, as this is a more relative value to be safe to base safe activity on. Time to peak torque, a measure of time from the start of muscular contraction to the point of the highest torque development. This value is an indicator of the muscle's functional ability to produce torque quickly. The value is taken from the peak torque repetition. Angle of peak torque, defined as the point in the range of motion where peak torque is produced. It usually occurs at the same range in the range of motion for similar movements and speeds. Angle of peak torque typically occurs in the mid-range of a motion. This should be at the point in the range of motion where the length-tension relationship of the muscle is maximal. This value is also taken from the peak torque repetition. Torque at 30 degrees. This value is calculated from the peak torque repetition and displays torque produced at preset angle in range of motion. This point in the range of motion can be reset in the software to evaluate other angles as needed. 30 degrees is typically used as it is a critical point in knee stabilization. This is the angle that is achieved many times in succession during normal ambulation. This should be compared bilaterally with torque values relatively close to one another. Torque at 0.2 seconds displays time rate of tension development. This value represents the amount of tension developed in this time. It has been documented that upon heel strike, it takes the leg extensors approximately 0.2 seconds to develop enough force to support the body in normal ambulation. Wilk determined that by this time, 80 to 90% of peak torque should be achieved in the knee extensors and should be evaluated as such. This value can be reset in the software as needed. Max rep total work, defined as the total muscular force output for the repetition with the greatest amount of work. The equation of the work is work equals force times distance. This is a better indicator of the function of the muscle group than peak torque, as torque must be maintained throughout the range of motion and shows more neuromuscular rehabilitation than peak torque values, as a muscle needs to keep maintaining torque over distance. The repetition with the most total work is called the max rep work. It should occur within the first few repetitions of a test bout. The units of measurement are Newton meters. Max work rep number. Previously stated, this is a repetition where the maximum amount of work was accomplished during the test bout. This can be used to determine if most of the work was accomplished at the beginning or the end of the test or exercise bout. The maximum amount of work in one repetition should occur within the first few reps of a test bout. Work to body weight ratio. Ratio displayed as a percentage of the maximum work rep to the subject's body weight, much like peak torque to body weight. This value needs to be high as it represents increased work value. Total work, the amount of work accomplished for the entire set. This represents the muscle's capability to maintain torque throughout the test bout. Total work is most useful to determine rehabilitation of an injury. In order to accomplish ADLs, movements must be maintained over distance. This value may be affected by low peak torque values or variations in the range of motion and should be evaluated as such. If a patient's overall torque production is low, the amount of work capability can be affected. If the range of motion is smaller on one side, the total work will be affected even if the peak torque is the same. Work first 1/3 and work last 1/3. The sum of work produced in the first 1/3 and last 1/3 of the test bout. With maximal effort from the patient, there should be more work in the first 1/3 of the reps and less work during the last 1/3 of the reps. If the patient does not give a consistent effort, the work completed in the first 1/3 may be less than the work completed in the last 1/3. This, along with a poor coefficient of variance, may be an indicator of poor effort by the subject due to pain, lack of effort, and poor instruction. This is a useful measure to determine work fatigue. As the patient improves his or her endurance, the work in the last 1/3 should start to become more and more equal. This in turn will produce a smaller work fatigue factor. Work fatigue. This is a ratio of difference between the first 1/3 and last 1/3 of work in the test bout. It is a valuable parameter in documenting progress during endurance training to detect the amount of fatigue throughout the test bout. As the subject progresses through an endurance training program, this value should increase as the work last one-third produced will get closer to the work first one-third. Average power. Power is equal to the amount of total work divided by the time to complete that total work. This value is used to provide a true measure of work rate intensity defined as total work divided by time. Power represents how quickly a muscle can produce force, an important value to evaluate as power development is important for injury prevention. Acceleration time. Total time used to reach isokinetic speed indicates a muscle's neuromuscular capabilities to move a limb from resting position to isokinetic speed. Deceleration time. Total time to go from isokinetic speed to zero indicates a muscle's neuromuscular capability to eccentrically control movement towards the end range of motion. Range of motion. This is the greatest range of motion the joint achieves during the set. This may vary from the set range of motion as the patient does not reach full range of motion, and allows analysis of the test curve in relation to range of motion. Agonist to antagonist ratio, reciprocal muscle ratio. Peak torque of hamstrings divided by peak torque of quadriceps. An imbalance may predispose a joint to injury as opposing muscle groups provide dynamic joint stability. These values may be on a normative value sheet. Gravity effect of torque. This is the torque effect produced by the weight of the limb and the attachment, used to eliminate additional torque applied to the muscle tested and gives a measure of true muscle torque production. The GT is added to torque when the limb is working against gravity. In the case of the quadriceps, a GT is subtracted from when working with gravity in the case of the hamstrings. This should be taken for each limb, as edema and atrophy may cause variations. Allows standardization between tests and subjects. Data interpretation. There is a correlation between the shape of the torque curve and the patient's symptoms. However, keep in mind that curves should have a consistent variation to them, and pathology should not be based on one curve or curves alone. They should be used in conjunction with other clinical findings. The four areas of the curve used in analysis are as follows: time rate of tension development, torque obtainment, force decay rate, and reciprocal innervation time. Time rate of torque development, TRTD. It is the upward slope of the torque curve and indicates how quickly torque is developed during muscle contraction. If the x and y axis are divided into 30-degree segments, the TRTD portion of the curve should be within the 60 to 90-degree portion. A prolonged TRTD indicates a problem developing torque quickly. TRTD can be examined relative to peak torque, measured from the start of the muscle contraction to the highest point on the torque curve, or predetermined torque value, predetermined time, so torque at 0.20 seconds, for example, specific point within the range of motion, so torque at 30 degrees, for example. Torque obtainment. Values include peak torque, highest point on the curve, work, total area under the curve. Pathologies are indicative of poor torque obtainment, exhibit problems maintaining torque, possibly associated with poor neuromuscular control, general weakness, or pain. Examples include chondromalacia patella and muscular tendinous strains. Force decay rate. The downward slope of the torque curve. This should be straight or convex and may be indicative of difficulty maintaining original, producing and maintaining force of the end range of motion. For example, a clinician sees concavity with ACL deficient knees between 20 to 30 degrees, commonly seen during a pivot shift test. Reciprocal innervation time. This is the time interval between the end of the agonist contraction and the beginning of the antagonist contraction. Reciprocal innervation time should have a V-shaped appearance. A prolonged reciprocal innervation time will appear as a U. The delay in the reciprocal innervation time may be due to a decreased time of recruitment for motor units at the neuromuscular level. By working in smaller ranges of motion and at higher speeds, this can be rehabilitated provided there are no disruptions at the neuromuscular level. Reciprocal innervation time is important during function, as a poor reciprocal innervation time means that a patient may have difficulty generating power. The ability to generate power is crucial to injury prevention. For example, the hamstring protects the ACL during movements that require quick change of direction or stop and start movements. Windowed versus all data. All data is equal to the records of all the data points. Windowed is any data below 70% of the set velocity is not computed. This eliminates torque generated prior to isokinetic speed and takes out end spikes from deceleration. The difference between windowed data and all data is that all data shows all the data points and windowed data will show only data which has reached a preset percentage of isokinetic speed. The software allows you to set a predetermined percentage of isokinetic speed to display. The default value is 70%. This means that anything under 70% of isokinetic speed will be eliminated when viewing windowed data. Windowing the data is advantageous to eliminate artifact spiking and may occur at higher isokinetic speeds as the attachment decelerates into the end range of motion stop. This can be seen as spikes towards the end range of motion. When the data is windowed, the curve is displayed as the patient's effort at the speed they are working at. Windowed data shows the patient's actual effort.